get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, welcome to Broken Healthcare. My name is Ray Kober, and I am thrilled to have in studio Anthony Masotto from Drexi. Did I get your name right, Anthony?
You did, Ray.
Indeed, indeed. Excellent. And Anthony is a former New Yorker. He lived here for a minute. He's got family here. So there's that piece of it. But then we lost him to the West Coast, San Diego for a little while. Now he's in Arizona. It's all over the place. But I ran into him at a panel at one of our events. I think
National Alliance, I believe. I was on that panel.
Yes.
High cost drugs.
Yes, exactly. And very insightful stuff. So tell us a little bit about kind of how you got to the panel. Did they pick you out of a hat? Did they find you somewhere? Like, were you under a rock? Where were you, Anthony?
No, I've been involved with those guys for, multiple years now. I did the PBM playbook for them the year before. I was part of that. So again, they're like-minded people, right? They're thinking about the same thing. They have a lot of employer groups running into the same issues that everybody else is. And, that was a hot button. It's going to be a hot button for a long time, high cost drugs.
Yeah, and so National Alliance is a coalition, right? They kind of band together and help their members understand that there are alternatives to the status quo.
Correct. Yeah. So the National Alliance kind of sits at the top and has all the tentacles down, right? But then every state, there's lots of different buying coalitions and education coalitions throughout the country that employers kind of partner with them, right? They want to know what's going on and what are the things that are hot topics and things that they can possibly help with in member education and where to get certain vendors, partners, things like that.
Yeah, and what was fascinating to me being there for the first time was just I'm walking amongst all the attendees and mixing it up, talking to people, and then hearing panels like yours. And I've been in kind of the anti-status quo, or let's just call it, because I'm not anti-status quo per se. I'm about the best thing for the situation, for the client, for the client's employees, members. But I'm milling around with the attendees, and I just had to shake my head and say, man, so many of them just didn't really have a clue as to what the potential was within their budget, which healthcare, as you know, is typically a top 1, 2, or 3, line item expense after payroll. And, to just think that how many of them are kind of in the safe bet. Like once upon a time, we heard and, we grew up with, no one gets fired for hiring IBM.
Exactly. 100%.
So now you have, these people that are responsible for this huge expense. And the safe bet is to stick with the insurance carrier in an ASO arrangement, which means simply that they're managing the plan as they see fit. And whose interest do you think they're managing for? Well, it's going to be for their shareholders and their stakeholders. And there's so much room for improvement there. And I think, having someone like you on a panel who's got years of experience. And how long have you been at this?
Oh my God. So I started in 2007. So going on 18 years.
It's been a minute.
It's been a minute.
So having someone like you, sitting in front of them as a expert in your space had to be eye-opening for, I think, many of those attendees.
Yeah. And you brought up like the ASO arrangement stuff, right? I mean, employer groups go self-funded to try and control costs, to control their spend. And yet they get into arrangements that they can't do those things. It was interesting. I was reading something this morning and people were talking about J codes, right? And you would think I'm self-insured. I can do whatever I want to do, right? If I want to carve out J codes and manage those in a different way, I should be able to do that. However, depending on the TPA you choose and the Buca network that you lease, they don't allow you to do that. And on top of that, they're also requiring you that they do all the prior authorization. So again, pick your partners wisely.
Yeah, for sure. It's I think, again, getting back to that IBM analogy, it's really easy for them, and particularly like I think if you frame it and you look at it, is a whole ecosystem at play here, right? So you have the insurance carriers, you have their brokers, you have then, if you kind of break down an insurance policy into the sum of its parts, and you're trying to look at the verticals of the supply chain, you have the PBM, you have the administration, but the biggest bucket is the claims bucket, right?
Correct.
And pharma is pretty much contending for the top spend in that claims bucket, right? It's around 30% now.
Right now, yeah. Right now it's about 30%. And again, that's for a fully credible case, right? I mean, you get into the smaller group space and your pharmacy spend could outspend your medical spend very easily. So, you think about, oh yeah, it's 30%, but that's in the entire pool, right?
It's why you have companies like CVS buying Aetna.
100%. And that's why you have Optum posting $26 billion in revenue, and it grows, double digit year over year.
Yeah.
That's not a mistake.
Yep.
Right. So they have created this monster, and they're completely satisfied with how it's running.
Of course, because it's running just fine for them. They're making money hand over fist. And who's paying for it? The organizations that are sponsoring the plan are most definitely paying for it. And the members that are, utilizing care, particularly like the high utilizers, the super utilizers, as we call them, are paying for it dearly.
Yeah. That was interesting because, 1/1 just came around, and there was an article that went out talking about, the seven ways to help save the plan money. Right. And once again, the number one thing on the list was to raise deductibles. Well, how much more can you shift costs back to your employees is the question, right? And employers are now faced with, do we start pulling more benefits away? Do we keep raising deductibles because they can't continue to pay for these drugs?
Yeah, I think all the air is out of that balloon. It's that ship has sailed. There's really nowhere to go. And, there are organizations out there that specialize in HRAs and, the iterations of HRAs. But if you're already in a spot where you're an employer organization and you offer nothing but an HSA plan, a high deductible plan that has your members, footing the bill to the tune of thousands of dollars, before insurance kicks in, which is, so many organizations out there in that boat. Where do you go from there? So I think we're going to start seeing, and we are seeing it, right? I think it was interesting because we spoke and you said, it's getting worse. It's not getting better. Right. So what did you mean by that?
Well, again, right. The drugs that are hitting the market. So if you look at the average drug cost approved in 2008 by the FDA was around $1,500 a year to treat a condition. In 2023, it was $240,000 to treat a condition. So what pharma is doing now, and we can get into this later around precision medicine and where they're going with AI and quantum computing and all these other things, like the drugs that are going to hit these plans, the drugs that are in development are revolutionary drugs, right? Yeah. But right now, pharma's going, hey, what conditions, what ailments do we not manage well today, right? It was not blood pressure. It's not, diabetes, right? All of that stuff is managed really well today. It's the rare diseases, the orphan diseases. It's the diseases that, 1 in 100,000 people get, right? Those are the ones that they're focused on because that's where they can drive an enormous amount of revenue.
Yeah. And for employer organizations that are out there looking at this, if you're in that bucket where you've kind of followed the advice of your broker consultant, to this point and gone down the road of, maybe you are as an organization trying to do the right thing by your employees. And I think most are trying to do the right thing by their employees.
I would agree with that.
Right. But the trouble is once all the air is out of the balloon and, even if you're as the employer organization taking on the lion's share of the expense of the increases, which most do, you're still an employee now or the member of the plan the spouse, the child, you're a family member of the employee that's also covered by the plan. And now you go to Access Care, and what we know is that most Americans have less than $1,000 saved for a rainy day, and we're saddling them with these high deductible plans that really now it's approaching $2,000, the average deductible, more or less. The last time I checked, it was $1,600. I'm quite confident it's north of that now. How do you manage this? And what you just said is very insightful, because now we have these whole other classes of drugs that are being produced by the pharmaceutical manufacturers. And let's say for the record, it's not all bad. Like some of the stuff is the difference between life and death.
1,000%.
But there's a cost for it.
That's right. So, you look at you made a point of, the deductibles continue to raise, right? And most Americans are making, say, $55,000 a year. They're on a high deductible health plan. That's before taxes and everything else. And then you tack on a $2,000 deductible or a $10,000 max out of pocket. And so I think one of the biggest pushbacks is, we don't want to disrupt our members, right? We don't want to put them in a spot where, well, what's more disruptive? Them going bankrupt and not affording their drug, their costs, right, in healthcare, or actually helping them navigate them. They might have to jump through a couple different hoops, but in doing that, right, they get the care that they need. A lot of employers can offer that care for no cost, right? You're enriching benefits, and at the same time, the plan is saving money, right? So there's ways to access, the same care, better care even, and also save money and enrich benefits. But again, that's a bigger conversation, and a lot of times too, the HR department, right? They think, oh my God, there's more things to manage. Therefore, it's going to be more work on me and my staff, and we just don't have the bandwidth to do that. So you get a lot of that pushback as well.
Yeah, no doubt. I think, it's really, I don't envy employers, right? Because what we know is that they're focused on their business. If they're a manufacturing company, they're focused on, producing their widgets. Yeah. If they're a services company, they're focused on their services. So once a year, this is kind of front and center on the table. And let's face it, for larger organizations, they have a human resources team. But even these companies with thousands of employees, typically the HR resources dedicated to benefits is really spread super thin.
Right.
So it's not that they have bad intentions, but the reality is they're ill-equipped to deal with the day-to-day and putting their finger on the pulse and knowing what folks like we do and the folks that run in our circles. We're the de facto experts. The trouble is they're relying on typically, the big box brokers that control the majority of the market, and their incentives are more aligned with the status quo, large insurance carrier incentives.
That's right.
And that's where there's a lot of, waste, fraud, and abuse.
Yeah, you bring up a good point too. Like, again, right? Brokers, consultants, right? Employers hire these individuals and these entities, right, to guide them in the right direction. But again, if they have misaligned incentives, if they're profiting off of, let's say, the higher costs you spend, right, my overrides and on my back end, right, that's going to the bottom line, right? So there's an issue there. The other thing is, you brought up the thing about, hey, I'm a manufacturer, I produce widgets, right? Let's say I'm a 1,000 life employer group. That 1,000 life employer group probably has a RX spend of somewhere around $3 million. I come in, right? I can save you 40% of your RX spend, right? $1.2 million. So I go to the CFO and go, hey, who is your number one salesperson? Tell me how many widgets do you sell all year long, right? I bring you $1.2 million on your 15% margin. Go hire somebody to help manage all of these other things, to expand the HR department, right? You hire a couple people, an extra couple $100,000, but in the end, you're putting $1 million on your bottom line, right? At the end of the day.
Right.
So where there's a will, there's a way to put all of this together and kind of deflect any kind of pushback of, hey, why do you guys continue to buy? 85% of the market continues to buy benefits the exact same way, even though they all know that there's stuff going on in the background.
Yep. Yeah. And it's so funny that you use the salesman example, because I use the same example, and I was honored to have one of my clients, Rob McKinney, was the former CEO of Raven Alaska, which was a client of ours. We saved them literally. I mean, it's going to sound ludicrous, especially to folks listening. They're going to be like, "You're full of shit, Ray." But we saved them 50% of their spend in their first year, and they weren't a huge organization. They had 500 odd employees. They had, roughly 200 people on plan, 200 to 250, depending upon, when we're talking about. And they were faced with a $2.8 million increase, not increase, but that was their proposed spend. It was a significant, like a 30% increase over what they had been spending. And they were in a fully insured plan with Blue Cross Blue Shield at the time. And, we came in and explained to Rob that, there's a better way to do this. And I'll just fast forward and say that, when we saved them this money, we delivered what we promised. And so he was appreciative of that. But when I had the opportunity to decompress with him, long after, he basically, I asked them, I said, so, $1.3 million, Rob. Now, this is like a small regional airline. It's kind of like a lifeline in Alaska, because if you've been to Alaska, there's a lot of water and there's a lot of mountains.
Yeah.
So the only way to get from point A to point B in any reasonable amount of time is you got to take a plane.
Yeah.
And so, their flights aren't terribly expensive, probably under $100 to $250, I would say, is the average cost. But nevertheless, there's a cost involved. And I said, how many airline tickets would you have to sell to realize a $1.3 million savings?
A lot of
it was
tickets.
Like a lot of airline tickets. Yeah. So explain, to our viewers and to our listeners, how is it possible? Like, how is it possible that little old Drexi can be better than CVS Caremark or Express Scripts or Optum? Why would I put my faith and trust in a little tiny company in comparison to the big three? And the big three, what percentage of the market do they own? And what are you up against? Is this a futile effort? Do you have no customers?
Oh no, I mean, so let's the last question first, right? So the big three, CVS has about 30% of the market. Optum and Express Scripts share about 25% each. So they're at about 80 to 85% of the market is controlled by the three PBMs, right?
And by the way, who owns the three PBMs?
Well, again, so Caremark, it actually bought Aetna, right? So they actually own the health plan. United owns Optum, and then Cigna owns Express Scripts.
There we go.
There you go. Those are the big three. So you talk about, how Drexi does what it does. And Drexi, again, while we're small in comparison, we've been growing. Since I came in 2001, we've had year-over-year growth of around 80%. We cover around 400,000 lives today, and we continue to grow. 2025 is going to be a big breakout year because, again, we're starting to go upstream, right? The larger employer groups are going, hey, we're sick and tired of these guys as well, but they just didn't want to be the first ones to go, right? They wanted to see the model kind of work its way through, and then once you can show all the things that you really can do and scale it, then you start seeing the big guys. But understanding that the vertical integration, right, of the big three is very important to understand, right? So we'll pick on United for a second because United was the most recent one to come out and say, hey, we're going to give back all the rebates, right, by 2028. Well, I don't know why it has to take till 2028 for you to do that. But understanding, so everything starts with their GPO.
They have to unwind.
They got to unwind everything. Yeah, right. They got to shift something somewhere so they're not losing profit. But everything starts with the GPO. So United's GPO is MSR, right?
GPO is
a group purchasing organization, right? So they created these group purchasing organizations for rebate contracts. So MSR is based in Ireland. Ireland then negotiates with Pharma to get all the rebates. But United, Optum, guess what? Negotiates with MSR, their own company, right, to tell them, what they're going to pass through in rebates. So one of two things are going to happen. Either MSR takes a bigger cut, right? The extra 2%.
Yeah.
Or, right, Optum just shifts the cost somewhere else, right? They increase specialty by 2% or whatever it is. At the end of the day, they're not giving up anything.
Right.
Right. You talk to anybody within those organizations, and trust me, I've talked to a lot of high level people, all the way from clinical to executives.
Yep.
Their number one goal is to increase top line revenue and maximize EBITDA. Everything that they do is around that and that alone.
Right.
All right.
And that in and of itself, I have no problem with, just in terms of it's the American way, right? It's a free enterprise model, and we're capitalists. And at the end of the day, they have a fiduciary responsibility to increase profit and show a return on investment to shareholders. Here's where my problem is. In healthcare, the way that they have done that is at issue. And now we're at a point where I think the shareholders are kind of used to this exponential growth.
Yes.
And now how are you the CEO that says we're at a point now where growth is going to slow down a lot? You're never going to hear that on a quarterly, earnings.
No,
earnings call.
no, you can't. The train's already left the station, right? I mean, there's just, and to your point, right? They've been the shareholders, everybody is just like, okay, we need our 20%, we need our 15% growth. We need this, right?
Yep.
This is the expectation that they've set.
Yeah.
And they've created this system, right? Of this really messed up system.
Yeah.
And everybody's pointing fingers at each other, right? So the PBMs are pointing fingers at Pharma. Pharma's like, it's not our fault, it's their fault. But and I mean, while I don't feel bad for Pharma, it's what's interesting, and this can kind of get into what are some of the things that we do at Drexi is Pharma gives 56 cents on the dollar back in some sort of funding, right? Most people don't realize that. So, for every dollar, they got 44 cents that they're utilizing for their profit, right? Well, so, and that goes back to everything from a rebate to copay cards to 340B drugs, all these free drugs, goods, and services. So they do give back. And what's interesting too is, if you look throughout anywhere else part of the world, Canada, the UK, Australia, all the major countries where we typically source drugs from, Pharma isn't charging $25,000 for Stelara in those countries, right?
Right.
They're charging $7-8 grand or whatever it may be because they've removed all of the fat, right? All the stuff that we've built into this healthcare system to pay everybody.
Yeah.
Everybody's got their hands in the cookie jar. So in order to really solve that problem, who's going to take their hand out first, right? So now you got legislation going, well, we're going to take everybody's hand out, right? That's what we want to do. And again, I don't know if that's the best way either, right? So,
but also, Anthony, good luck with that, right? So while I am super encouraged, and it's not a blue or red issue as I see it, this is about all Americans, regardless of where you stand politically. I for one, I won't put my words in the mouths of all, but I'm very encouraged by what I'm seeing with the RFK Jr.'s appointment of HHS, Dr. McCarry's FDA, and because I know and I've invested the time listening to hours of interviews. I've heard Dr. McCarry speak publicly multiple times. I've read their books, so it's not like I'm not taking my news from Facebook or from a snippet here or a snippet there. And I don't think if you put in the work, you could be anything but encouraged by what's going on, because we're in long need of an overhaul, like definition of insanity, right? Doing the same thing over and over again, expecting a different result. This is anything but that. The jury is out on whether or not they will actually make a difference. I'm encouraged by what I'm seeing, but on the other hand, we have a $5 trillion economy that's called healthcare, and that's the buzzsaw that they're up against.
Right.
And I would never bet against that buzzsaw.
Yeah, I mean, look, the thing that people forget, I think, too, is all United's and everyone's 401k, right? I mean, the profitability of those companies drives a lot of growth, right, within our economy. And just coming in and saying, oh, okay, United, we're going to restrict you from your $26 billion of revenue every year. Like that, you can't do that, right? You would blow up the whole system. So there's going to be steps, I think, in the system. I think you brought up RFK and some of this other stuff. I think he's bringing in light the issues that really stem from a lot of our sicknesses is the food that we eat, right? The processed food has driven our population into obesity, right? 60-70% of Americans are obese in one way, shape, or form.
Yeah.
That is a huge problem, right? And on top of it, right, food lobbyists are just as big as pharma lobbyists, right? So the two of them together, like, hey, we want more, this processed stuff. And pharma's like, yeah, do that because we have all these drugs that, the rise of GLP-1s, right? They're talking by 2035, that's $140 billion business.
Yeah.
To put that into perspective, Humira at its peak was doing 30 billion, right? Oncology does 70 billion. That's double in the next, 7-8 years of, and again, they're trying to get that drug approved for everything.
Yeah. Sleep
apnea, cardiovascular disease, alcoholism, you name it, right? You can get a GLP-1.
Yeah.
So,
no, listen, I'm part of the problem. I'm obese. Like I didn't always used to be this way. I'm sitting here 5'9", 250 pounds, 35% body fat. No bueno. Like, and for me, I go up and down. Like I've been extremely fit, like P90X. I'm not going to say shredded, but 15 to 20% body fat, feeling really good. But look, I'm kind of ensnared in the system, right? I like alcohol. I like eating all the wrong things. And I would say overall, my diet is pretty healthy, but we all kind of find a way to cope. And for some people, they're taking a happy pill. For me, it's a glass of tequila, and one leads to another, and it's too many glasses of tequila, right? And so now I'm at a point where, it's enough. And I hope the next time we see one another that I turn 60 pounds of fat into 20 pounds of muscle.
I would love to see that, right? Absolutely.
I'm working on it, baby. But the truth is, that is, I think, the struggle. And I don't think I'm a bad guy. No. I don't think anybody that's heavy or overweight is they're not bad people. But I think as society goes, we're so full of shit about, they're a little heavy. They need to lose a few pounds. Call it what it is. And I'm not saying it's not right to make anyone feel bad. You don't want to talk down on it, but you also want to acknowledge there is a problem. Like that is not a healthy shell that you're in, and you could do something about it. And I think, step one is just kind of acknowledging that. And, let's just stop the horse shit of pussyfooting around, because I'm not going to get where I told you I'd like to go by sitting in my podcast studio on my ass 8 hours a day. I need to set a timer and, take a brisk walk. I need to get my heart rate pumping. I need to lift. I need to do what I need to do. And I know what I need to do. And I need to cut the alcohol out. And I need to really eat whole, natural, real foods and get away from stuff that, as an Italian, bread, and pasta, and pizza. You got me blowing snots over here.
Now, I mean, to your point, right there, you look at other parts of the world, like, Italy, for instance, right? They eat pasta all the time, but they eat fresh pasta, right? They're making it themselves. They're not buying processed, non-GMO processed pasta, right? The other thing too is we've become a society of the easy button, right? Like we don't want to put in the work, right? I mean, I don't know many people that get up at 4:30 in the morning and go to the gym, right? Because that's the only time in their day that they can do it, right? They'd rather have the couple hours of sleep. So of course, right? Pharma knows this, right? They wanted to make people believe that there's an
but wait a second. You told me that you do that.
Do what?
You wake up at 4:30 to go.
It's the time. That's the only time that I have to go to the gym, right? I mean, other than that, I'm in the office, I'm working, I'm traveling, whatever it may be.
Yeah.
That's my time. So I've made it a priority in my life to, I food prep. I lift in the mornings. That's just part of who I am. Right. And it wasn't overnight, right? It just took time and over years and years and years, right? It becomes just second nature, right? This is what we do.
Right.
Just like the other way, right? You know, second nature is I come home after work and I pour a glass of wine and I eat, a bag of chips and I watch TV. It's all just part of routine.
Right.
So changing routine is going to have typically, will have an outcome, right? And, good or bad or indifferent. But the thing to think about, like these GLP-1s, right? Well, yes, it will make you lose weight.
Yeah.
Right. But it's not necessarily good weight. Right. I mean, if you don't do the other things, if you don't eat the right food, if you don't work out, then essentially what it does is just eat your body. It eats everything in your body. And so now you're just a skinnier person of what you were before, but you're no more healthier.
Yeah. You're losing muscle along with fat.
Everything. Right. And we really don't know the long-term results of being on these drugs for 5, 6, 7, 8, 9, 10 years. What does that look like?
Right.
And we're already starting to see people have, major complications, but at the same time, there's a lot of people taking these drugs too. You kind of look back at like, COVID and, you had a lot of bad reactions. Well, if you gave Tylenol to 300 million people, you're going to have some bad experiences. Right.
Right.
So
yeah.
Look, at the end of the day, it's a holistic approach, right? There's a play with pharma. Absolutely. Right. If something can help me get to my end goal while I'm doing all these other things, that's not a bad thing, to your point.
Right. So I think people have to assess the risk, and we're not medical doctors. So I think it's wise to find a medical professional that you can confide in, who you can build a relationship with where there's a trust bond. I think it's really got to start with that. And let's face it, in our healthcare system today, it's not designed for that. No. If you look at the regular traditional healthcare system and you have a big logo and you are proud of that logo that's on your ID card, and that gives you access to a network of doctors and providers. In New York City metro area, which is where we're recording today, where I'm from, good luck getting an appointment with a primary care physician that's worth their salt in less than 3-4 months.
Right.
For me, it's typically 6 months out. And when you think about what a big name healthcare insurance policy costs, I mean, for insured spouse coverage, it's north of 30 grand easy. So think about that. You're basically buying a car every year with your insurance policy that you can't access if you need it, unless you really need it. If you're an emergency,
that's right,
you need a surgery, that sort of thing, that's what that's backstopping you for. But this is where we are. And does it make any sense?
No, it doesn't. And I think you're getting a shortage of nurses and doctors, and they don't want to get into this space, right?
Right.
They don't want to go work for United, who owns the most. Like, they're buying everything up and creating a machine out of it where you got to see so many patients. You got to do this. You got to do that. It's not personalized care anymore. So even in Arizona, where I'm at, and I'm in a pretty prominent part of outside of Phoenix, but what you're starting to see is a lot of doctors going back to like home services, right? So it's a subscription type model where I have a personal relationship with a provider. I pay him, $300 a month, but he takes care of the entire family, right? He shows up, right? We have conversations. It's just how medicine used to be, right? Small town medicine, right? The doc knew everybody, kind of thing.
Yeah.
And he helped manage your care from everything from corns on your toes to, God forbid you had to have something else done.
So one of my favorite scenes of all time is, did you ever see Doc Hollywood?
I did. That's kind of what I'm thinking about.
Like Dr. Hogue, I think, or something like that. He basically comes out in the middle of the night. They wake him up out of bed, because they're gonna
take that kid to surgery,
right?
Or something.
They're gonna crack young Timmy's chest open to do a procedure on him, and he opens up a can of Coke and he hands it to the kid. The kid burps, and he's fine,
right?
And that gets back to that, that physician patient relationship that is evaporated in the name of corporate profits and greed. And it's not the physicians, by the way. My experience, and I've had the privilege of interviewing many physicians on the show, nurses, nurse practitioners, registered nurses. These are people that got into the profession because they want to help people. Truly, by and large, that is the mission. There are plenty of other ways that they can make more money than being a doctor, generally speaking. There are exceptions, plastic surgeons, et cetera, et cetera. But the reality is they got in it for all the right reasons. But now I've interviewed direct primary care physicians who broke away from, the traditional hospital systems that are gobbling up primary care practices, and private equity is involved, and it's all in the name of money and profit. But now we've turned our physicians into glorified salespeople. So you walk in and they're not only paid by the volume of patients that they see, which means that they're going to spend as little time with you as possible.
Yep.
But they're also bonused on relative value units, the amount of revenue that they drive within the healthcare system.
Upsells.
That they operate in. Upsells,
Yeah.
exactly. So the reality is we have a system that is really broken in many different levels. I, for one, am going to be breaking away from the traditional healthcare model. I get my coverage through my wife, who's a speech language pathologist. She works at a preschool. We have United Healthcare. It's good insurance, Anthony.
Yeah.
It's the best coverage because of that logo.
Right.
Well, I'm leaving United Healthcare at this renewal, and I'm going to go with a direct primary care model and probably a faith-based, community shared backup system, so that in the event of, God forbid, something catastrophic, I'm still covered. I'm not going to lose my house. I'm not going to lose my assets.
Right.
But I'm no longer going to be subject to the traditional healthcare system because it's just not where I want to be anymore.
Yeah, and again, you're seeing more and more employers and individuals do that. So at AMPS, we're the background for a lot of big health shares, right? So we understand kind of this process. And what's really interesting is, like, as you may mention that doctors and nurses, they got into this to do the right thing.
And by the way, you mentioned AMPS.
Yep.
How is AMPS connected to Drexi?
So AMPS is the umbrella company that owns. We sit under the Advanced Medical Pricing Solutions umbrella, right? So it's actually Drexi. We have another entity called Price Dynamics, which is our RBP division, and our True Price, which is our we have a contract automation product. And then we have Claim Insight, which is our payment integrity business. You think about, if someone goes into a facility, has a surgery, well, we look at that. It goes through the system, our edits before the bill gets paid, right? To ensure that there's no duplicate billings, no upcodings. There's certain rules and regs.
That never happens.
Oh yeah, no, never. I mean, that's a whole nother episode if you want to start talking about the things that happen within the hospital system.
Yeah.
Around, upcharges and, things that were ordered but never rendered. You could, you go in for an MRI, you come out, you had 3 MRIs, right? That kind of thing, because you didn't feel good one day.
Yeah.
Because what happens is the doctors don't talk to billing, right? The systems don't. They just put stuff in the system. It automatically feeds the billing, and then they just bill.
Yeah.
And so 95% or more bills have errors on them, and the hospitals know it. They've told us that they've known it. And it's not their job to give you a clean bill, right? So it's the employer or the TPA or whoever is on behalf of the member making sure that the payments are made accurately and at the right price. That's not the hospital's job.
Unintentional mistakes.
Unintentional mistakes. For some reason, they don't talk to each other. But anyway, and then Drexi, right? So Drexi sits under that umbrella.
Got it. And so your primary role at Drexi is what?
Pharmacy benefits, right? So just like CVS, Caremark, just like Express Scripts, just like Optum, we run the RX prescription benefit for the members and the plan. But getting back to how we are different.
Yeah.
So,
and by the way, it's not a small organization, right? How many employees do you guys have?
We have about 350 employees.
Yeah, it's a good sized business.
Good sized business again, and we're growing, fairly quickly, which is great. It's so, and we have 2 offices. We have an office in Atlanta, and then corporate offices in Phoenix, downtown Phoenix, Arizona. Right.
And so when I look at the healthcare landscape and I see people like, Mark Cuban jumping in, he's not jumping into the game because he's anti-capitalism. he sees an opportunity, right? And so there's a lot of, kind of, I guess, because of who he is, and he's, A-list celebrity in the public, maybe B-list, in the public profile, the public limelight. He has drawn a lot of attention to what's going on in the PBM space. Are you comfortable comparing with not to put you on the spot, are you comfortable competing with an organization like that? Are they doing the same exact things? Or
so you got to remember, Cuban is a pharmacy, right? He's not an administrator, right? So he's a mail order pharmacy that you can get generic drugs from, right?
Okay.
He's actually in my network, right? I think he's doing the right thing, right? It's all about giving people options. And in order to do that, you have to give them the information, right? This is what I'm charging you for the drugs, right? This is what we're making on them. And you decide if this is the best place to buy your medication. So one of the things that how Drexi is different is that we have both an app and a web portal where members or plans or whoever can go on, type in their drug, and it will tell them where the best place to buy that medication is, because all pharmacies are not created equally, right? They all contract differently. So as an example, you're sitting in the doctor's office, he's writing you a prescription. The last question he always asks you is, where would you like it sent?
Right.
What's your pharmacy? There you pick it up.
Right.
And the answer to that question can have huge cost variance. So let's go back. You're on a high deductible health plan, which 70% of the Americans are on high deductible health plans. I say, let me take that atorvastatin script and let's go to CVS. Okay. You walk into CVS for a 90-day fill. They're going to charge you $50 for that atorvastatin fill. In the exact same parking lot is typically a grocery store, or across the street, there's a Walgreens. You can buy that exact same drug. It just has Walgreens on it, or, the grocery store,
Stop and Shop, whatever.
Stop and Shop, and you buy for 15. So we'll drive across the street to save 5 cents on gas, but we won't walk through the same parking lot to save $30, $40, $50 on a prescription, on a simple prescription.
Yeah.
The number one prescribed drug in the U.S. is atorvastatin, right? Or a rovastatin.
Yep.
That's crazy, right? Then that's just a simple drug, right? So the way that we look at it is, as long as diagnosis is correct, where you get your drug should have the same outcome.
Yeah.
Right. So that's one way, right? Giving the people the information to be able to be good consumers, right? I mean, think about it. We're the best consumers on the planet.
Yeah.
Right? People sit outside on Black Friday to save $200 on a TV.
Right.
Right. Like I said, they'll do it. Right. You show them
and fight
for the TV, for Tickle Me Elmo. They're in fights. Right. But anyway, so it's not that they won't do it. They just have been educated as, oh, you have a $10 copay, or you have a $50 copay, or it doesn't matter where you go. It's all the same.
Yeah.
Right. That has been ingrained in people's minds for since they've been buying insurance. Right. And then you got the high cost stuff. Right. So, I gave the example of Stelara earlier. That's a product made by Johnson & Johnson. It's for Crohn's and rheumatoid arthritis. And, it's an autoimmune drug. Johnson doesn't even make the drugs in the U.S., right? They make that drug and most of their biologics in the Netherlands, right? And so that's where it's manufactured. That's where it's bottled. That's where everything pilled up. There it is. So, and then they ship it all over the world. They ship it to Canada. They ship it to UK. So, but cost differential. So if you have a patient on Stelara, it's going to cost on average around, $250,000 a year to treat that patient. $25,000, $30,000, $40,000 every couple of months.
Wow.
Just for that medication. So I can get the same drug in the same box with a maple leaf on it instead of a U.S. flag. That's cold shipped, no different than you get the drug today, right? Whether you get it from Accredo, if you're with ESI, or you get it from CVS Specialty, they're still mailing it to you, right? It's not like you go down to their local retail pharmacy and pick it up.
Yep.
48 hours on your doorstep. And now all of a sudden I can give that drug to that member for free, because the plan just saved $17,000 a fill. So it's not rocket science to be able to do all these things. Right. And then on top of that, now you even have access around 340B drugs too. And we can talk a little bit about that too.
No, I would like to talk about that. Broken Healthcare Podcast is brought to you by Benefixa Healthcare Consultants. Visit benefixa.com to learn what's possible. reduce the cost of healthcare for your organization, deliver better outcomes for your people, and yes, design health plans that give your people a path to $0 out-of-pocket costs for healthcare. Visit benefixa.com. But getting back to international for a second. So one of my curiosities is I've heard in our circle, some people say, well, it's illegal to source drugs internationally. And yet self-funded plans do it all day long. Is there a legality? Is there a concern about getting drugs from, like, I know that the main, countries are Canada, Australia, New Zealand, people that are English speaking, so you could read the labels, which makes a lot of sense.
Yep.
Is there some legality or red tape involved?
I think if you, we have, many legal opinions, right? And, based on the way that the law is written, self-importation up to 90 days is completely allowed, right? Both, even the Biden and the former Trump administration, both through HHS said, hey, look, we're not going to do anything about trying grandma getting her drug,
right?
For cheaper so she can take the medications.
Well, that makes sense.
Now there is, language around only importing FDA approved medications, right? So there's like RIMS products, very highly products that have oversight that you cannot import, right? So understanding that, and there were some bad actors in the space that were importing everything and not following, the law, right? So that maybe left a bad taste to some people. But also, right, the big PBMs are trying to lobby like the FDA and all these entities to say, stop this, right? Don't allow them to, because guess what, right? Now there's another option that we can access drugs, right? And then on top of that, last year, a year ago, the FDA gave approval to the state of Florida to import drugs from Canada for the state employees, right? And there are multiple states from Colorado to New Hampshire, all over the country that have passed legislation,
right,
to allow for importing drugs into the U.S.
If it's good enough for them, it's got to be good enough for your average employer.
And I'll make this final point, right? At the end of the day, people talk about this all the time. I say, cannabis at the federal level is illegal.
Yep.
At the state level, all of a sudden they're allowed, but ultimately it's still illegal at the federal level, right?
Yeah.
So again, there's a lot of talking outside of both, sides of their mouth where, it's like, oh, well, if we can't profit on it, then it's illegal, right? That kind of thing.
And at the base level, I think you have to look at this and say, is it right that you should be able to acquire this drug in any European country for less than you can here? Is it right that you should be able to acquire this in Australia or Canada, or pick a flavor
100%
for less than you can here? This is America. Like, we should be transparent. We should understand, what the price is. And I think one thing that you might be able to help the audience with is, how is price established? What is AWP? What does that mean? What is kind of the starting price? And then I have a lot of folks that I talk to, really smart people, CFOs, finance experts, that talk about, but they get rebates. So they're in an ASO arrangement. The insurance carrier is doing all the administration for the plan. They're filling the drugs because they have a very profitable unit that they make a lot of money filling and dispensing drugs. But they return rebates to their clients. What do you say? What is the starting price, Anthony? Well, let's start there.
So there are, and that's a big problem, right? Is that there is no singular starting price. I mean, there's multiple ones that you can use, right? You have First Data Bank is one national pricing source. You have Medispan, which is one national pricing source. You have NADAC, which is another pricing source, a little bit more limited. And then you have the wholesalers that use WAC. You have on the medical side, average sale price for the drugs on the J codes, ASP. So they're all over the place.
Yep.
Right. And when you enter into a contract with a PBM, what that starting price is really important to define in the contract, right? It's kind of like, I'll give you an example. Furniture stores, right? They're always going out of business, 70% off, right? Well, understanding that they're usually raising the starting price up and then discounting to get to the same point that they've always been at, right? That's the game of optics, right? Hey, I'm going to give you this really big discount. Okay, well, what are you going to charge me for it? Don't worry about it. We'll figure it all out at the end of the year.
Yeah.
Right. So, So what I tell people is, one, make sure that you have a singular pricing source. And that's a really big problem with pharmacy consultants is, right, whose pricing source do they use? Because if I'm showing you discounts off of a certain pricing source, right, like a specialty minus 20 off of Medispan would be different than a 20% off of NADAC or a proprietary pricing source that the big three have internally.
Mm-hmm.
So again, right, all I really care about at the end of the day is what is the net cost? What is discount after rebate? Bam, that's what you should care about.
Yeah.
Because everything else is smoke and mirrors. It can be shifted, right? It's all about contracts. So specialty generics, right, is this big debate, right? That was the Johnson & Johnson lawsuit. They were charging absorbent amounts of money for these drugs. Drugs that were actually went generic. Right. So as these specialty drugs, which is also a made up term, right? There's really no such thing as specialty.
Right.
There's only brand and generic drugs. It's only one of the two.
Yep.
But if I can define a drug and not say, all right, so a cancer medication goes generic. And when it does that, the drug becomes really deeply discounted, right? Like upwards of like 99%, depending on the drug.
Right.
But if me as the PBMs can say, you know what, because this is a specialty drug, I'm going to keep it in the specialty discount bucket. I don't want to give it a 95% discount. I only want to give it a 20% discount. So now a drug that has a very high starting price, because again, it's still a complex drug, that doesn't change. But instead of giving the 95% discount and giving that drug to that plan and that member for $100, I give a 20% discount and sell it for $16,000. That's the ultimate spread, essentially, but it's all about contract language.
Right.
And what they can and cannot do with the claims.
Right.
And where they can and cannot put them in certain buckets. Because again, as soon as I give you a guarantee, I am now hedging that guarantee because I don't want to miss it.
Yeah.
If I miss the guarantee, then I have to give you something for that.
Right.
And in the sense of the big three, they don't charge you anything. So if they miss a guarantee, they're now giving it back to you dollar for dollar. If in fact they truly missed it based on the language in the contract, which now you're talking about, like there's soft audits and hard audits. Hard audits can go upwards of 12 to 18 months fighting with them about what's in and what's out.
Wow.
So again, at the end of the day, you pick a PBM, one who you trust, right? Because realistically, if you're going to stay in the status quo and not do anything, there are no deals.
Right.
There are no deals on brand medications. CVS is not buying Stelara any cheaper than I am. Now, because they're a little bit bigger organization, they might be able to give a little bit bigger rebate, but that's if they give it back to you, which they're not doing either.
Yep.
So that's hence the reason why you can do all these different things, because look, I don't make money on drugs. I'm going to get you the same drug.
Right.
Your employee's happy. They're not going bankrupt over this medication, and you're saving money. It's a perfect triangle, right?
So you don't make money on drugs. How do you make money?
Administration, right? Why PBMs are actually put in place in the first place was an administrator. It was an administrator to be able to pay pharmacies, to negotiate contracts, to do clinical work, right? That's why PBMs were invented in the first place. No different than a TPA for the medical side.
Yeah.
Right? So PBMs are just the opposite for the RX, right?
Right.
We just administer it. We pay, we monitor, we do all these different things on behalf of the plan. Well, PBMs figured out, like, look at these, we can buy, sell, right? I can buy for X and sell for Y.
Right.
And there's nothing wrong with that, right? If that's how you want to make money, that's fine.
Yeah.
And if you want to continue to buy drugs from them, that's fine.
Right.
But you get what I'm saying? Like you just don't, you don't really there's not a lot of transparency when it comes from that.
So I think when you think about this, like logically as a business professional, you don't even have to be a business professional. Just think about it logically. There's money to be made on the administrative side. There's money to be made, in terms of the way that it's being made now, especially by the big three. There are over 30 different bucket profit centers and ways for them to make money within, a plan, which sounds absurd, but, they're making money on spread pricing. They're, making money on clawbacks, which is ridiculous. There are multiple ways for them to make money. And you're sitting here today saying, well, we're a good size organization. We, contractually are prohibited from making money all of those ways. I'm not sure if I
Yeah,
don't
yeah.
want to misstate.
Yeah.
If that's not the case, please say it's not. But my understanding that you are contractually prohibited from making money in those ways, and that you're a thriving, growing company, and you're able to do that simply by fulfilling your administrative duty to your clients. Am I hearing that right?
Yeah, I mean, look, at the end of the day, right? I'm just like, you're going to pay for a service, right? And in return for that service, I'm going to the results are going to be this,
Yeah.
right? And if I can do that, right, that's a good relationship.
Yeah.
Right. So if you pay me and I promise to you what I'm going to do,
Yeah.
and we do that's what we do.
Yeah.
So at Drexi, we built Drexi with a PBM without conflicts.
Yep.
So I don't prefer product. I don't own any product, and I don't dispense any product, right? Just through my network and contracts and navigation, we're trying to get people to the right drug for the right cost.
Yeah.
Right.
Yeah.
So you talk about preferring product,
Yep.
right? So the big guys are managing that formulary, right, to drive rebate, right? That's what they want. They want to maximize that rebate. And in order to maximize that rebate, they have to maximize the cost, right? The money's got to come from somewhere.
Yeah.
Right. So the CFOs are like, oh, they're paying us a big rebate. Well, we pay rebates too, right? If there's a drug that gets a rebate, we go out and get it.
Yeah.
But what I'm not going to do is drive your members to highly rebatable drugs, because all that means is that you're going to cut a bigger check.
Yeah.
So you're playing this game. All right, I'm going to give you $100 and you're going to give me, 30 back. It's not a very good deal, right?
Yeah.
So with that being said, you think about insulin, right? There was a debate on insulin for 20 years about how expensive insulin was. So we'll pick on Lilly, because the two major manufacturers of insulin are Lilly, Eli Lilly, and Novo Nordisk, right? Novo makes Novolog, and Lilly makes Humalog. All right. So Humalog Quickie Pens, right, is to manage your diabetes, and the Quickie Pen costs like around $100
Mm-hmm.
per pen.
Okay.
Right. You need probably 5 to 10 pens a month to manage your diabetes. So let's say $10,000.
Mm.
On the exact same production line that Humalog Quickie Pens are made, Insulin Lispro Quickie Pen is made. It is the bioidentical of that drug. It just has a different label.
Mm.
It's like walking into Costco and buying Kirkland vodka. We all know it's made by Grey Goose. It's the same thing, but I pay $20 instead of $60.
Wow.
You can buy that exact same Insulin Lispro Quickie Pen for $9. So now you can manage the same diabetic for $100 that you're managing for $1,000.
Wow.
Now, of course, there's some rebate in there and stuff like that, but at the end of the day, you're still reducing the cost of that diabetic. One, they're on a high deductible health plan. I only got to pay $100 for my 10 pens, right? Versus I had to pay $1,000 for my other 10 pens. So guess what? Now the diabetics are rationing their insulins, right? You have, kids that have needed insulin, you get it one day. That shouldn't be that way.
No.
And again, the formularies are built right that way to prefer the one product. You drive to the one, whether or not that person's on a high deductible health plan or not, because they don't, at the end of the day, they don't care.
Right. That's infuriating. It really is. Like, I think about my mom. She basically raised me and my brothers, single-handedly. My dad passed just after my second birthday, and she lost her first husband, who came back from World War II with some type of a congenital heart condition. He passed away when he was 26. So she did not win the lottery when it came to husbands, right? But I think about women in my mom's position who are doing everything that they can, busting their ass to make ends meet, working multiple jobs, walking around with holes in their shoes. And I hear a story like, and look, the other thing the audience needs to know is this isn't, something that was even going on in the 60s and the 70s, right? This whole drug culture explosion is pretty recent.
Yeah, in the last within the last 15 years,
right,
or so.
But now, you have people that are operating, I think, in good faith, and I'm talking about HR executives, CFOs, finance professionals, CEOs that are getting involved in their healthcare expense, and they think they're doing the right thing by putting out coverage that, is one of the big labels, not realizing what's going on behind the scenes, and certainly not they're not in the know about what you just shared. They don't know that their employee is really being taken to the cleaners. They just know that it's an expensive drug on their plan, and they're focused on their primary day-to-day business. They're not focused on our business. And that's what really drives me nuts. It's just like, you want to shake these people and just say, would you just please wake up? Pretty please.
Yeah. I mean, look, we're not in the business of saying no. Like, we want to get, you the right drug, because if you're a healthier, more productive individual, that means the employer's getting more out. Everybody is on the right path.
Yeah.
Right. But you even ask providers that are writing prescriptions, right? Most of them do not know how much these drugs actually cost.
Yeah.
Right. I mean, again, going back to the Humira example, right? I mean, you're talking about Humira was costing plans, back in the day, $100,000 a year.
Yeah.
Right. You're literally giving somebody freaking sports car every single year.
Right.
And then when you ask them to, and so when it's part of this thing of,
or a condo, $100,000,
$100,000, right? And that's a cheap drug, right? I mean, that's not that bad. That's only $8,000 a month. So to say that, you're going to disrupt members, right? Well, look, Mr. Member, like, this drug you should tell the member this drug costs $100,000, right? Your employer is paying this every single year for you. I can get it for half that cost. You get it for free. Most members, 95% of the members are like, I'm good with that. Like, I'm getting it for free. They're saving money. Oh, and by the way, them saving $50,000 and them saving $50,000 on this person and this person and this person. Guess what happens at renewal?
Right.
Guess what? Now all of a sudden the renewal stays flat.
Right.
Or the employer can actually drop it. The reinsurance comes down, right? So people don't realize too, the increased costs in drugs, right? When reinsurance looks at it, they don't care about what your rebate is. They only care what is the gross cost of the drug, because that's what they're on the hook for.
Of course. They're looking at managing risk.
Managing risk.
That's it.
So when reinsurers love what we're doing.
Of course.
Right? It's like, oh my God, like, oh, by the way, that person was going to get a laser at $250.
Right.
Now the drug's going to cost $100. There's no more laser.
Right. And so a laser is when an employer basically takes on more responsibility for paying out of pocket.
Correct.
Before insurance kicks in.
Correct.
And, maybe they were at 75,000, but the Poindexter with the slide ruler that's figuring out, what their experience is and, how to rate them.
That's right.
In terms of risk, says, no, for this one, it's not going to be 75,000. You're going to have to assume a $250,000 risk.
That's right.
Or you're going to pay dearly for it.
That's right.
And so it doesn't become an option. So again, using myself as an example, I have gout, and I take febuxostat to manage my uric acid level. And so if I go according to the plan, and I'm with, this is not a knock against United. They just happen to be my insurance company, and OptumRx is their PBM. If I go through the plan, it's just under $200 for a 90-day supply. Knowing what I know and not being connected, with your, PBM or any other PBM, because we're with Optum, I go out to goodrx.com. I click on, I put in febuxostat, and it gives me a bunch of options where I could get the same drug for a fraction of that. Yeah. $60 for a 90-day supply, as opposed to $200 for a 90-day supply. It's not right that I know that and I take advantage of that, and so many other people don't.
That's right. And
one of the things that you mentioned, Anthony, is your organization has an app that can help folks with that. You played right into your hands.
I play right into my hands.
But that's where I'm going with this, because so many HR folks are focused on, and rightly so, what is the impact of culture going to be? Is going with Drexi going to turn lives upside down? Is our phone going to be ringing off the hook with, people that, can't get access to their medication and drugs? So maybe you could speak to that.
Yeah. I mean, what's really interesting is, we give out the, Drexi, we have a subscription card as well, right? It's kind of like GoodRx, but they just get access to my commercial rates. They pay a flat fee every month. And essentially they get the same price that I pass on to my commercial plans, right? But there's absolutely people. I mean, you look at there's about 100 million prescriptions left at the pharmacy every year due to costs, right? So again, when we have the app, right, as much as we want people to find the best price, and because one, we want them to take their medication, right? If the doctor's writing you a prescription, he's expecting you to fill it. And this is going back to my point of like, doctors don't even know, they don't know your plan. They don't know what's covered. They don't know what the cost, they don't know nothing.
Right.
So if people can't afford them, right, or they don't take them, what is the downward? What happens on the other side? Do they end? If I'm rationing my insulin and I have an episode and I end up in the ER, well, that's going to cost the plan 10 times more than it would have been to just pay for all my insulin.
No doubt.
Right. So what we're also trying to do is cover adherence.
Right.
Right. So we want people to be adherent to their drugs.
Yeah.
They write them a prescription for a drug. I'll give you a great example. This is a plan we took on a year ago, right? In 2024, we saved them $1 million. It was a group of 1,700 employees, all doctors, by the way.
Wow. In
December, they got a new doc that joined the company, and it wasn't even the doctor, it was his spouse, was taking $700,000 of drugs.
It's always the spouse.
The spouse. One of her drugs was $48,000 a year. She had another drug that was about $8,000, and on and on and on and on. And he was a doctor.
Right.
So, and she, because it's a different way to, to kind of go through the navigation around how we're going to access the drugs, this, that, and the other, so there's things that we do. We pen the claim. We want to talk to the member. She was like, there is no way we can afford these drugs. And my husband's a doctor, right? At the end of the day. So, because of one of the drugs was $48,000 a month, like Pharma, you can go to Pharma. They gave that drug for free, right? It was a very obscure medication that she was taking. So they got that one for free. That was an instant $500,000 worth of savings to the plan right out of the gate. And then the other drug that she was taking,
that was through like a PAP program,
through an MSP PAP program, right? That gave her access. And then the other drug we got through Canada, right? Which saved again, at the end of the day, we saved the group like $650,000 on 2 medications, which, by the way, she said we can't even afford.
Right.
And if I don't take this medication, like I'm not, I might not be around, kind of thing. Oh, God. So, anyways, at the end of the day, here. So you're right. This one.
Yep.
So again, this is in Arizona, but you can get it for $15.
Right.
That's a 30-day fill, right? For $15. So, do the math for $60.
Right.
You can get your 90-day fill. But that's, if you really look, when like United, the big guys.
Well, less than 60, probably more like $40.
Oh, sorry, $45. Yeah, it's 15 a piece.
Yeah.
But if you look at the average spread of the big guys, right? And we do these analysis all the time. On average, the big guys usually spread somewhere between $25 and $40 per generic fill. So again, 85 to 90% of your fills are generic drugs.
Right.
So again, you're a group of 1,000 people. You're probably going to have around 12,000 claims, of which 9,000 of them are generic. So I always say it's not grand larceny, but they're literally pickpocketing you $20 a time or $25 at a time, and they're doing it 9,000 times.
Right.
That's how one of the ways that they make their money.
Yeah. And so, to those that say that they're getting rebates back, and well, we do get a lot of money back in rebates, they're not getting all the money.
No.
Yeah. And so that's the issue, right? It's okay. So you don't mind being robbed. You just don't want to be robbed a lot.
Exactly. Just don't take all my money. Just take some of it. Can you leave me a little bit, right? In the piggy bank kind of thing. But going back to your point, right? So this all starts with the GPOs, right? So you have Zinc, which is CVS. You have Ascent, which is ESI, and then you have MSR, which is United.
And they're in Ireland.
Well, Ireland, and they're all offshore.
Netherlands.
They're all offshore because when the ACA passed, it gave safe harbor to the GPOs. So you can't even look at them. You have no idea what's going on with them from a financial perspective.
Right.
So the close.
Well, wait, let me stop you there, because that's crazy, right? So, inspect what you expect, but you can't inspect what you don't have. The data is behind an iron curtain.
That's right.
And you don't have any access to the data.
Nope.
And they have no obligation to give you the data.
Nope.
So you're flying blind.
You're flying blind. So again, I think that, again, backroom deals, what was going on when, because they were trying to negotiate, right, for the drugs, right? Remember, Medicare was going to negotiate on 10 drugs. And so these are all backroom deals. So they, of course, PBMs have rooms of attorneys, right?
Yeah.
These people are thinking 10 years down the road.
Yep.
So you think they're going to pass some legislation, do some stuff over here. It's never going to change, right? At the end of the day, they're going to have a really tough time changing all of that because, again, they're just too big, too powerful, too strong.
Right.
But anyways, they all start there. So the closer you can get to those 3 GPOs from a PBM perspective, if I can contract directly with those guys, the more rebate value I can get back. But the problem is again, you have, the big 3, big 3, they contract with those guys. And then realistically, for the most part, everybody else contracts underneath that. So you're at least 3 down. But then you have aggregators, right? So some entities, some PBMs are maybe 3-4 spots down. So by the time everybody takes their cut, right, their pound of flesh, essentially, right, you're left with what you got. Maybe 30% out of a pot of, say, 50, right? Because, everyone's taking their little bit. So the closer you can get up, typically you can gain maybe another 5 points, right? So our average rebate return is somewhere between 30 and 35%. On because it's all, and if it's a really big group, right, that, they really want, you can try to get upwards in the 40 percentile and 40% or so. Yeah. But again, it all depends on what your drug mix is, what drugs are they taking, are they on highly rebatable drugs? It's all, that's not the game you want to play.
No.
Trust me.
No, and it kind of begs the question, what is one to do? And I think clearly, if you look at the market and you see that the big 3 are controlling the vast majority of this, and you've been paying attention to what we've been talking about, perhaps it might be worth the exercise of repricing your drug spend. Get as much data as you can. As an employer, you are entitled to the data, especially with the passage of the CAA. Doesn't mean it's not going to be difficult to get. It doesn't mean that your current broker and your current insurance carrier are gonna try to block you every which way that they can. But you do have a right to that data. And with that data, with a complete run of what you spent on drugs, and having an organization like yours do a comparison, if that's something that you do, you can see what would have been spent versus what was spent. And, data and knowledge is power. And,
that's right.
And so I would imagine you encourage prospective clients to go through an exercise like that.
1,000%, right? If, again, you legally should be able to get the data. But even last week, right, a large entity went to they're buying through a coalition, right? Said, I want my data. And they said, well, you can have this information, but we're not going to give you like the ingredient cost because it's part of the coalition. It's like, no, I want all of my information, right? Like I'm legally obligated based on, the no gag clauses. I need the data. But that's an automatic response from them, right? You ask for data, they're going to say yes to this and they're going to say no to that because they don't want to give it to you, because as soon as they give it to you, all of a sudden now you find out all the stuff that they're doing, right? They're charging me $16,000 for a drug I can buy for $100, right? That's the stuff that they don't want you to see. Yeah. Because that's how they make money. Yep. So yes, absolutely. When I get the data, I'll break it down to the claim level and show you everything. Yeah. And what's really eye-opening there, again, right, because I'm using a singular pricing source when you talk about discounts and how is the group's actually running versus what they have in their contract. All of a sudden you're like, hey, based on this pricing source, like your specialty is running at 17.8, but your contract says you have a specialty discount of 21%. Well, that's weird, right? Because at the end of the day, you have to buy the specialty from CVS. Right. And guess what? CVS has their own pricing source. Yep. So my 21%, my 17.8, again, at the end of the day, is the same as CVS's 21. Right. But then people are trying to sell on a spreadsheet. I'm going to put a bunch of discounts on a spreadsheet, and you're, just optically, you're going to go, oh, I'll take the 21. Right. 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 So funny story. So when I was in the pharmacy consultant before I was running a PBM, and we were having a conversation with an exec for one of the big 3. And we had proprietary information database where we would actually sit behind the scenes and reprice all the claims all the time to make sure that they were abiding by the contract, this, that, and the other. So we're like, look, we see how you do all these different things. Like, how do your reps actually go out to the broker community and employer groups and actually sell? So he goes, he pulls out some business cards and he fans them out and he goes, all right, this is a 85% discount. This is a 88% discount. This is a 90. This is a 92. Which one would you like? And I go, we want the 92. He goes, it doesn't matter. They're all the same.
What's the starting price?
No, not that one, the starting price and what I can put in the contract.
Right.
Because I change one comma or one word or this, that, and the other. At the end of the day, we're going to get to the same number. So it's all,
it's a shell game.
It's bullshit.
It's a shell game.
Bullshit.
Yeah, it's crazy. Yeah. So recently, something came across my desk and a union was in negotiation with management, pretty large company, figured, somewhere north of 10,000 lives. And I was asked for an opinion because the union was, negotiating with the company and they were looking at their contract. And so the union wants, management, of course, to pay for the insurance coverage. And so they had like 4 different plans, all pretty much 3 super rich plans, low deductibles, low out of pocket, big label, and, one like consumer driven health plan, out of the 4. And I'm looking at it and I'm saying to myself, well, I mean, they're asking the wrong questions, right? Because everybody is kind of focused on what you just described. Like, pick one, pick a card, any card. The trouble is not the card, it's the deck.
100%. The deck is loaded in their favor.
You're playing a rigged game.
That's right.
And so what needs to happen is employer organizations need to figure out what are the right questions to ask. And if they continue to make decisions based on a bullshit number, they're going to continue to get a bullshit result. So they have to go back and they have to put their thinking caps on and say, well, how can we do better at this? And should we be really putting this out to an RFP when we're using our incumbent broker to kind of manage the guidelines of the RFP? Or even if we do it internally, how can we put this out so that we are putting ourselves or setting ourselves up in a position to win? And there aren't enough, in my opinion, employer organizations that have the wherewithal to even know how to begin designing a proper RFP. Because if you're focused on the copays, the coinsurance, the deductibles, the max out of pockets, you got your eye on the wrong prize. I don't know if you'd agree or disagree with that, but
yeah.
Really, I looked at what I was presented with, knowing like they're probably north of $30,000 PEPY, this company, per employee per year. I would bet a lot of money that I'm in the ballpark. And I know based on, my expertise that, they rightfully should be, if you want to go nutso, half of that, and maybe even, as ludicrous as it might sound, less than a third of that is what the potential is. But you have to start asking the right questions.
These RFPs have gotten so out of hand. I'm telling you right now, the stuff that we're answering, it's almost like they just pulled stuff from everywhere and just threw it all in there. And they don't even understand what they're asking half the time. I truly believe that.
Yeah.
Because at the end of the day, the only thing that they go to is the financial piece. And then they start there. So if the financial piece is up to their liking, then all of a sudden they're interested in all these other pieces. So I think the RFP process has gotten really kind of out of whack. And then what they really have to ask themselves is, for $30,000 an employee per year, what are we actually getting out of this?
Right.
Are we getting a healthier population? Are our employees actually happy with the program that we have put in play?
Right.
And I would have to say, ultimately, probably no. Right. So again, but they've dug themselves into this mess over years and years and years of mismanagement. Right. Yeah. The expectation of just flipping the switch and changing it all in a year is impossible.
Yeah.
So you're going to have to take it in pieces. And what is the biggest pain point right now that you're facing?
Right.
My guess is 99% of employers are drugs is the number one pain point in their health plan today.
Yeah. Yeah. And another way of looking at this, though, from the perspective of a finance professional, or anyone in the C-suite with P&L responsibility, let's say they are spending $30,000. Let's say they're spending $15,000 a year. And I know for a fact they're paying way more than that.
Yeah.
Let's say it's $15,000 a year per employee per year. 10,000 employees, they're spending $150 million a year on their health insurance,
Yep.
right? So if we propose that we could save them 30%, what is that? 45 million? 45 million in savings. What if you take 10 million of that savings and you give it to the union back to bonus their employees? I mean, am I some kind of a fucking genius?
No.
Is this rocket science?
No.
Is that possible? All day long, that's possible. All day long. And, to your point, it's not about just the money savings. It's about increasing the quality of care. It's about delivering drugs that cost $100,000, $250,000 plus to members for free. And in some cases to the plan for free.
Yes.
And so if you can develop and design plans with $0 out of pocket to the employees or the union members, wouldn't that be a win for the union? Wouldn't that be a win for the organization?
I mean, when you think about that, right, you're talking about, so you save them 30%, $50 million, right, on $150 million.
There you go.
Right, or $45 million.
Yep.
In 3 years,
yep,
you just got an entire year for free.
Bingo. That's it.
And now when they say, you know what, we want to give you increase in wages, we want to do this, we want to do that, we're all working together for the same goal.
It's crazy.
I mean, you got to think of that's wild that you can save that amount of money.
Yep.
And not give it, to United or whoever.
Yep.
That's not rocket science. That's not hard to figure out. And if the employees and the union members realize this is what's going on, hey, just so you guys know, every 3 years or whatever it is, you're going to have an extra $150 million. But I just have to have you jump through this hoop, and we do this for union groups too, by the way, right? And they love it, right? Unions are all about more, more, more. We want more for our members. I get that.
Yep.
And in this day and age, that is rare. It's less, less, less. Like, we can't give you more.
Yeah. But again, Anthony, it goes back to them, union leadership, not understanding what questions to ask to begin with.
Correct.
Because it's by design. It's a $5 trillion industry for a reason.
That's right.
Right. And the PBM attorneys are always the smartest guys in the room. They're looking way, way, way down the road.
That's right.
And so you have to start thinking beyond the constraints of the game that you're being asked to play. And you have to start making the rules to your own game. And really, that's probably not the best way to put it. You have to realize that there's a different set of rules by which you can play the game.
Right.
It's already there. The infrastructure is already there. But you have to know, as an employer, it's completely realistic and within my ability to reduce costs by a minimum of 30% if you're playing in a fully insured game or you're self-funded in an ASO arrangement. This is not difficult to do and deliver outcomes to your members that are far better than anything that they've ever seen.
Yeah, I mean, if you're a fully insured plan, right, you don't get anything back, right? Just on your drug spend alone, if I didn't do anything, you save 30%. And you know why? Because I give you 30% back in rebate.
Yeah. Right.
What other entities don't know, like the big fully insured and even the self-funded, that there's rebates on the medical side too, right? That they never see.
Yeah.
Right. So the big carriers are submitting for those too that just go right to the bottom line.
Yeah.
They're not giving those back to anybody. But people don't know that. There's J-code rebates, there's all these rebates that they're submitting for that they're not passing back through.
Yeah. No, it's crazy. They're making money hand over fist. You mentioned the 340B program.
Yeah.
So I want you to talk just a little bit about 340B and how hospitals might be using that to their advantage.
So yeah, the 340B program was developed, right, for underserved hospitals and underserved markets, right? A way for them to get funding, essentially, to provide more services to the community, right?
Yep.
So it's the problem with that now, and so and part of that program is they're able to buy really really expensive drugs, right, through the program at a significant price reduction, right? Like they buy Humira for like say $100, right? But what they then do is they mark it up, right? And then they sell it to the downstream, to the plan or to the member, say for $2,000. And they're supposed to reinvest that $1,900, right, into the community and expand their services and things like that.
Yeah.
And it's gotten really out of hand, right? Like 3,400 Walgreens pharmacies are now considered covered entities. The big PBMs are using it as a profit, kind of profit, vertical. And then what they're doing is, and then the hospitals are using it now to buy more hospitals, right? So they're creating these big systems and not really giving that value back down to the plans and the communities and the members and all that stuff. So
right,
it's been becoming this greed, because it's easy to make money, right? That's easy to make a lot of money.
Yeah.
However, if you find the right entities that are, kind of leveraging this or have 340B pharmacies, you can use it for good, right? So there's no income verification to access 340B pricing, right? It's just you have to be under the care of the covered entity. That prescriber writes you the prescription, and then you can access to that drug, and it has to be in the same state. Like you can't mail order it across the country, right? So there's regs around state level compliance. What's typically happens, and again, this depends on the entity that you're using and how they're making money. But if you get to a true 340B type program, you're actually getting almost the full rebate from Pharma, right? So that 50% or 50, whatever that number is back on that drug that they're giving back in funding, that's essentially what you can acquire the drug for. So you're stepping up, right, all the way, and you're kind of carving out all the big GPOs, right, and saying, now, okay, I have access to this. So going back to the Stelara example, that's $25,000 a month, right? You can buy it on a 340B program for like around 11. So that tells you that there's around a $14,000 rebate for Stelara. Well, one, you don't got to wait for the rebate, right? Because the rebates come like 6 months after the close of the quarter, so they're always lagged, right? So you may cut these big checks and you got to pay right away, hoping that you get a big check at 6 months down the road, right? So you're shifting this cost. So now the CFO goes, oh, well, I just paid for exactly what I should have paid for, right? But then on the reinsurance side, all of a sudden, right, that now they can underwrite all of the drugs to that price, right? Because hey, this is what we're implementing. So in order to get this drug, you're going to have to go through this channel. And so we're just navigating. So now all of a sudden, right, now I got a reduction on reinsurance. I maximize my rebate. I don't have to worry about, am I getting it all? Am I not getting it all? And I'm still giving it to my members for nothing, right? So now I have healthier members. They're getting the drugs that they need. We're not based on exactly what the PBM wants us to get and acquire, what drugs, right? So, the other thing to think about too is now PBMs are now getting in the drug business.
Yeah.
Right. They're creating, partnerships and they're white labeling products and things like that. That's just going to make it even worse, right? Because now I have my own product for autoimmune. Yeah. Now I'm going to restrict you access to other drugs. So again, at the end of the day, you're not getting to the best clinical outcome in that model. Yeah. Because that drug might not work for that person.
Yeah. And it sounds to me like there's a lot of room in that model to kind of fudge the numbers.
Big time.
Right. So you have these, hospitals that are owned by private equity that are all about, bottom line profit for the shareholders, gaming the system to their own advantage and not necessarily doing what the program intended, which was specifically to reinvest in a community that is not an affluent community that needs support. It goes against the grain of what the program was intended to do.
That's right. So if I'm getting like an infusion, right, in one of those hospitals, why wouldn't I be getting access to that through a 340B program? Right. Again, you might. But at the end of the day, you're not getting a 340B price, right? They might be working that drug through the 340B channel.
Right.
which by doing that as well, a couple things happen. If you go through the 340B channel, there is no rebate.
Right.
So now the hospital just excluded a rebate from you that if they went down that channel, oh, and by the way, I didn't get a deal either because they charged me, they charged me too much money for that drug.
Right. Yeah. So in English, what's going on is, Anthony is, God forbid, needing Humira in this hospital system. Anthony is not downtrodden. He's not one of these people that is impoverished, but the hospital is acquiring the drug as if Anthony is.
Correct.
They're selling the drug to Anthony via the hospital bill at full price plus, but it's a shell game. They're acquiring the drug here based on a 340B program. They're marking the drug up as if no 340B program is involved. Anthony's paying, the system is making money. And it's, listen, let's not throw the baby out with the bathwater and say that this is going on everywhere.
It's not.
But it's going on.
It's going on.
It's going on for sure. And so this is some of the stuff that's out there. So look, Anthony, you and I could talk for days. we didn't even scratch the surface today.
No, we did not.
So I'll make you a deal. If you're open to it, we'll have you back and we'll talk about some other stuff. But it's important for our guests to know, how do they engage you? Do you work directly with employers? Do you typically work through brokers, through TPAs, all of the above? And what's the best way for any organization that might be interested, or if it's a TPA, what's the best way for them to find you and engage with you?
Yeah. So the answer is all of the above, right? Even some employers come direct, right? It just really depends on what they're trying to accomplish.
Yep.
But you can find, you can go to our website, drexi.com. If there's a broker or a TP that wants to reach out directly to me, I'm assuming you share stuff online and stuff. I can give you all that contact information and my email address. But then there's also like info@drexi.com. You go to our website and again, type in your information and it'll get routed to the right person and we can reach out and kind of show you what we can do.
Awesome. Well, hey, thank you so much for being a guest on our show. Knowledge is power. We appreciate you sharing your knowledge with our audience. With what's going on in healthcare today, you have to kind of pull back the curtain. If you suspect that something's going on, odds are it's
going on.
It's probably
follow your gut. Like if you think something's off, there's something off.
For sure. So until next time, folks, thank you for tuning in. Peace and love always. Take care.
All right, that's a wrap. Hit like, follow, and subscribe, and we'll catch you next time.